Good morning. I hope everyone is doing well today. And thank you so much for joining the Medicare Relaunch Program, Part 2. If you haven't had a chance to listen to the first one, please do so. Go back. It is on the internet. You'll find it recorded and logged there. But just to run through our agenda today and what we're going to be hitting on, we will have an hour-long meeting as far as giving you information. I'll try to keep it as tight and concise as possible, though we do have a lot to cover. And I'm hoping for the last 30 to 20 minutes, not hoping, but we will, for the last 30 to 20 minutes, we will have Q&A. Today, since we're not able to speak to what an ABN is and how to use one last time in Part 1, we're going to speak to that today. First of all, hit that. Secondly, then we'll talk briefly about how to obtain medical records from the certifying physician, understanding your remittance advice, meaning where is my money, and talk briefly on fraud and abuse. I think that's an important topic simply because we'll be rolling right into what a prepayment review is, what a post-payment audit is, how do we handle those, and then what overpayments and refunds are and how to handle those as well. Just to give you another brief overview of the corporate medical team, and just in case you guys don't remember from last time, Dr. Bill, Betty, Sherry, and myself are part of the medical team. We have our number of our responsibilities are there to the right, and what we do for you guys. So we are here for you to assist. Okay, so let's dive right in. Using an ABN, I'm going to have the tabs, you'll see tab squares up to the left, so you'll know that when I don't know if you've already had a chance to download the papers from yesterday that's on the internet. If not, that's fine. If so, this is the tabs that we are in at that time, so it'll help you keep up with us. All right, so tab 1, using an ABN. So what exactly is an ABN? An ABN is called an Advanced Beneficiary Notice of Non-Coverage. This is simply a notice letting the beneficiary know and Medicare know that the beneficiary that Medicare may not pay for an item. So, and it's also intended to assist the beneficiary in making a decision, an informed decision, whether or not they want that particular deluxe item, for example. I know that I'd had a franchisee give me a call and ask if, he turned someone away because they wanted a pair of boots. They're diabetics and wanted a pair of boots that would have fallen within the category of a diabetic shoe, but it was a boot, and so it was very costly and definitely a deluxe item. So instead of that, he could have used an ABN. So we'll talk more about exactly how he can do that. And also, of course, it protects you, the supplier, from being liable for the additional costs. And there are some very important points to keep in mind when and if you decide to use an ABN, because we can't use it all the time. It's not a pass to go, if you will. So why would we use an ABN? Well, one, if the item is not medically necessary, or if there's overutilization, or there's no physician order. Okay, so we'll look at that again in a minute. So when do we use? So when is an ABN considered unacceptable? And this is very important because, of course, they're going to be scrutinized when and if you do use them and submit them. An ABN is a form that is given out by CMS, and these are forms that you would handwrite on them, and you would make sure that they are legible and readable, of course. And when the beneficiary is in front of you and you're needing to fill out an ABN, you're believing that the whatever's going on is not medically necessary. For example, let's back up. you see the medical notes. You have requested the medical notes from the physician prior to dispensing the footwear, and you know that the medical notes does not mirror the statement of certifying physician, and it will not be covered. And you have called the physician and told them, I need these notes do not work. They do not match the SCP, and the physician is not listening, is not returning the phone calls, is not responding. The office is not responding. In these type of situations, and hopefully these are not routine situations, then you would tell the beneficiary, look, this is the situation. Your physician did write an order. You do have an SCP, a statement of certifying physician, but the medical notes that I have received do not mirror the SCP and do not show medical necessity. So you would explain this, and you're empowering your client as well for them to understand that this is going to be a non-covered item, that Medicare will not cover it. So you would tell the beneficiary, say, we have an ABN that you can sign so that you understand that it's not covered. Of course, we're never misleading or coercing the beneficiary to sign it. And we give them time. We give them time to review it, to study it, and also to go to their physician, because some of these guys would like to have the opportunity to visit with their physician and speak to them themselves. And I know I've spoken to a couple of franchisees who've done exactly that and let their client handle it, and they did, and they were able to come back with the proper note. So the ABN was never necessary. If for whatever reason the beneficiary is not able to understand and is not for whatever reason is not in their right mind, the person who is the power of attorney should be there and should be the one signing that. So you make sure that you make that notation on the ABN. If you take a look within tab 5 that I gave you during part 1, you'll see that there's a great explanation for each section and where the power of attorney would sign. I cannot say this enough. This ABN cannot be routine. It is not something that you can fall upon for every single client or for most clients. This is something that should be considered out of the ordinary. Also, an ABN cannot be considered generic, which means that the ABN must state the specific reason the denial of a payment is expected. So within the reason area, and with using the example I just gave you, you would say that the statement of certifying physician does not mirror the certifying physician's medical notes. Therefore, it is not it is not going to be considered medically necessary. So that's a very clear statement. So therefore, Medicare knows that when the beneficiary signed, they understood clearly the situation. Also, an ABN can never be signed and dated more than a year prior to dispensing whatever footwear that we're speaking to through the ABN. So it has to be within a 12-month period. Also, a blanket ABN can never be given, which is an ABN which is given for all items dispensed. Of course, sometimes it might fall in that category with us, meaning inserts and shoes. That would be fine. But we can't just say, whenever Susie Smith comes in, here's a blanket ABN for all the items that she has, of course. And also, we cannot just hand over a blank ABN and have the beneficiary sign it. That is incorrect and must be spoken with them at length prior to having them sign it. Again, because this is them, this is their rights that they're handing over, and they're going to have to open up their pocket to pay you. Also, when you do use an ABN, you will have to use a modifier when billing. So, for example, if the A5500 shoes is what you are having an ABN put together for. You would bill the GA modifier along with the A5500, okay? And then, of course, you would put left, if it's a left foot, right foot would be the next modifier, and the following modifier would be KX, meaning that you have all the documentation on file, including a completed and signed ABN. And what I would most certainly do as well is make a copy of an ABN and hand it to the beneficiary as well, so that way they can have it. Just to let you guys know, with the questions that you give me on chat, please continue to do that, and I will be happy to work on answering them at the end of the period. Thanks. All right, tab 8. So we're going to dive right into part 2. Part 2. I'm sorry, I was looking at the chat. All right, so part 2, tab 8. Problems obtaining medical records. We touched on this a bit in part 1, but I wanted to really speak through this because I gave you quite a bit of paperwork to look at that's on the internet for you to use if you would so choose. The fax cover sheets and different types of letters and so on, and so we'll go through that. This is, of course, when and if you decide to obtain medical records prior to, when and if you decide to obtain medical records prior to dispensing the footwear or after the footwear. I gave you 2 different types of fax cover sheets if there is a CMS audit in place, or if you've made the business decision to start requesting the medical records prior to dispensing. So they think those are very well marked, and you can see that. I think the thing to really bring out and speak to is that we want to make sure that that when you write the fax, and if you decide not to use what we've given you here, make sure that you're clearly requesting what you do need. You need to make sure that the diagnosis of diabetes is within the medical notes, to make sure you have the complete office visit notes, and you want to make sure that the documentation on the foot condition is within those notes. I've had a number of franchisees tell me, you know what, I don't want to see all the notes that the physician did on this person for their full exam. But within the LCD and the policy, it very clearly shows that they want to see a comprehensive diabetic checkup of their patient. And what that means is that there's going to be a comprehensive examination. So you are an allied healthcare professional, and of course you do go by the confidentiality rules of HIPAA. So what you do see in their records is confidential, and you keep it within your confidential Medicare spot, so that way they're locked and everything, no one else can obtain those records. All right, let's see. Also, when you're faxing off, requesting the medical records, I thought it would be a great idea to just to also send them a statement of certifying physician in the written order. Make sure that you title that, have a title page in front of that so they know exactly what they're looking at. And also telling them that, it does need to, make sure that your notes are mirroring, because more than likely you're not speaking to the physician. You're speaking to the office manager or you're speaking to the nurse, and you're letting them know what the situation is and that the SCP needs to mirror the medical notes. Also, depending on which jurisdiction you're in, you will send the jurisdictional letter from the medical director, from your medical director, along with that so they clearly understand. Also, Dr. Bill put together, you'll find a great letter from Dr. Bill that he put together for you. So that way you can send this along with those letters if you so choose. You can take a look at it yourself. Basically, it just says, I, Dr. William Faddick, Medical Director of Foot Solutions, am reaching out to you for my licensed podorthist. And of course, if you're not in a licensed state, then you would say certified podorthist. And then just to give them more talk to them more from a doctor-to-doctor level. Also, within that section, we have a doctor's chart checklist. So that way, when you pull those medical records, and perhaps you're not used to looking at them and seeing exactly what should be within, then you perhaps want to use this checklist. And when you're going through the checklist, if there's still some confusion, don't hesitate to call me, Sherry, or Dr. Bill, and have us take a look at those notes. We're happy to do that and assist you with that. That's what we're here for. All right. Let's see here. All right. So I thought I'd give you some live examples that could be very helpful. I had a franchisee contact me with some theoretical questions, I guess. What if? And I thought they were very interesting. I thought I should bring them up to the group because this was for Jurisdiction C, so I did reach out to contact within Jurisdiction C for their interpretation and what they thought. This is an ex-auditor, actually, who's now a provider outreach representative for Cigna Government Services. And because he was in the auditing trenches, I thought he would give a really great thought for us to this. So the first question is, what if the certifying physician circles 3 conditions on the statement, and that when you pull the medical records, only one of the conditions of the 3 that were circled are actually documented within the notes? Would that be sufficient to pass a review or audit? Well, he took a look at that and he said, you know what, as long as the condition that's documented within the notes is the medical condition, meaning it's within the LCD and policy that you have, needed to qualify the patient for that item being billed, then yes, that would be sufficient. He believed that was his interpretation. And this is something we're just talking through. This is not gold. This is not something that would forever pass every single audit. I just want to be clear, because this is all relying on interpretation of LCD and policy by your jurisdiction. The second question was, the certifying physician circles peripheral neuropathy with callus formation. And then on the SCP, he crosses out with callus formation. Within the medical notes, of course, it just speaks to peripheral neuropathy and doesn't speak to callus formation. Would that pass? And he had said no, it would definitely not pass, because within the LCD, it specifically states that the patient must have peripheral neuropathy with callus formation, and therefore the medical notes do not reflect that, do not show that. So then it would not. He did not believe it would pass an audit. The next question is somewhat similar to that one. The certifying physician circles peripheral neuropathy with callus formation, but only within the medical notes. He only speaks to peripheral neuropathy. So because he only speaks peripheral neuropathy, not including the callus formation, therefore it would not pass a review or audit. So, I think it's important here to talk through a little more and just say that when you do review those medical notes, and if they do not, and if you're doing this prior to dispensing, you would want to go and speak with the physician or the nurse, more than likely, to let them know the situation, that due to these policies and LCDs and so on, that it would not pass a review. We do have, you could use some sort of checklist and say, this is what is required, but we cannot give any type of form to the physician for them to fill out for you, because Medicare also wants to see the notes are organic, not something that you have fed them and had them check the boxes on. I think some of you have already seen this particular thought from a provider outreach representative from Cigna, from Jurisdiction C, and I thought it was strong enough that we should even just have it one more time and talk to you about it. When you do not receive the complete medical records from the physician, what are we to do as suppliers? And because we are working so closely, and I'm just paraphrasing here what Cigna said, because we work so closely with the physicians, we do count on them for our referrals, but so do everyone else. Nowadays, it's not a matter of if, but it's a matter of when you're going to be audited or reviewed. Your records are going to be reviewed. So I just want you to really hone in on the medical records and speak with and educate your referring physician. If they refuse to update these notes, then unfortunately, well, not unfortunately, but that you don't want to give away the footwear for free. So perhaps you do not accept those referrals any longer. That might be something hard to swallow, but might be in your better interest, simply because you would not then have, if you ever did go through an audit or review, the documentation would not back that up and you would give the product away for free. Of course, that is a business decision, what you determine you would like to do. Okay. Tab 9, fraud and abuse. What is it? All right, we've heard about fraud and abuse. We know this is some of the reason, or a lot of the reason why these auditors are out there. And I think it's important just to take a look at, just to be real clear, fraud is intentional deception or misrepresentation of the facts, simply put. Abuse describes incidents or practices that are inconsistent with accepted, sound medical, business, or fiscal practices. So they are slightly different. One is intentional, the other is not. But both are considered penalty-wise. Let's take a look at some examples. Underneath fraud, altering claim forms to obtain higher payments. Taking a look at this, let's take an example of that. When you alter claim forms to higher payments, I could even see an example such as the physician prescribes 3 pairs of custom inserts for you to dispense for their client. And instead of supplying all 3 custom inserts, you only supplying 1 pair of custom inserts and 2 pairs of over-the-counter inserts, while billing for only custom. So in this case, you are supplying to your patient one pair of custom and 2 pair of over-the-counter, and then you're billing Medicare for 3 pairs of custom. That would definitely be considered fraud. Also, falsifying beneficiary address, saying that they live somewhere other than where they do live. That's considered fraud. Of course, talk about kickback and soliciting for referring patients to be referred to you. That's considered fraud. Also, misrepresenting the diagnosis to justify a service on the SCP or written order. That would definitely be considered fraud as well. It's written here, falsification of CMNs or SCPs. Taking a look at abuse, claims for services not medically necessary. We can take a look at that in depth there. Routine waivers of coinsurance or deductibles. I know that we have a variety of suppliers out there, not us, our competitors, who are routinely waiving coinsurance. That 20% that should be collected from the Medicare beneficiary when they don't have that secondary insurance. And that is definitely considered abuse because you must collect. Also, the supplier violation of Medicare participation agreements or supplier standards. So you've got a supplier standards that are readily available within each jurisdiction on the home page for you guys to look at. I know a lot of us get DVDs of them as well, or I should say CDs, sorry, so that we can have time to look at the electronic copies. So we want to make sure that we're not violating those as well. And of course, and I don't want to be the harbor of all of this ugly, but I just also really want to really stress to you guys that the medical team, this is why we're here. We are here to have your back, to follow all of this for you, to assist you in every way that we can, so that way your medical records are in order, the documentation is in order, policy is in order, you understanding what you're reading, and there is no instance of fraud or abuse. All right, so understanding the remittance advice. We all get a remittance advice if we are Medicare accredited. This is simply what some of us call an EOB, an explanation of benefit as well. I think some of us know it more readily as that. Medicare calls it an RA, or remittance advice. And it's just simply a notice of payments and adjustments that we, the supplier, even the physicians and the billers and the members, that we all receive from Medicare, showing that their decision of coverage for the billed items. So what do we do with that remittance advice? You guys do a lot with that. We find out what's been paid, we post the decisions, we post the payments, we identify reasons for adjustments. We know that we have to submit a secondary claim from here, or they've maybe done it for you. So you're still waiting for the payment of the 20% in this specific case. Also to assist you in quickly identifying potential problems, meaning that if you have to appeal something, it alerts you to that right away normally. So what I want to do is I'd also like to zero in on some of those odd-looking codes that you do receive when you guys do get those remittance advices. And if you have decided not to submit it electronically, your claims, you're receiving paper checks without remittance advice and or EOBs. You can start, there is a software, and what I'll do is I'll submit that to you guys during the FAQs of where you can download the software to receive electronic RAs in this case. Because I know a lot of you, it can get very frustrating knowing where to put, where and whose money should be where. Also, what is an adjustment? So anyway, so these are the different types of adjustments, of course, that we look at: denied, zero payments, partial payments, reduced payments, penalties applied, et cetera, et cetera. Nothing surprising there. All right, so what exactly are the different codes? And we're going to take you've got within your packet, within that tab, what is it now, 10, I think, that we are, I've got a sample RA for you to look at. If you don't have something like that in front of you, and also I'm going to take some bits and pieces and just really take a look at those for you now. But just to briefly go through the 4 different categories, there are group codes. Group codes identify the financially responsible party or the general category of payment adjustment. For example, you'll see a CO, meaning contractual obligation. A lot of us who are Medicare accredited, we are obviously under contractual obligation to follow the adjustment. There are something called CARCs, which is a claim adjustment reason code, and these provide financial information about the claim decisions, meaning you usually see the group codes and the CARCs together, so CO-3. So meaning this is a co-payment amount that your client should have paid. Remittance advice remark codes, they call them RARCs. These are also used in conjunction with CARCs and RAs. So, and I'm not trying to confuse you. I hope I'm not. But just so I thought it was interesting because whenever time I was looking in the past at a remittance code, it was like I was trying to read Greek and really understand, what is this? And so when I found this information, it sort of just opened that up for me, and I was able to not have to be on the phone so much with Medicare. And then also, lastly, we have something called PLARCs, and these are provider-level adjustment reason codes. These are something not related specific to a claim or service, but this is more information for you at the provider level of what you need to understand what's going on with that claim or claim line. All right, so taking a close look at a remittance advice. This is a one claim line, and there's no PHI here, even though you see Henry and Nichols. This is actually something I pulled from a Medicare workshop I went to. But so you'll see very clearly here on the far left side, patient responsibility. I think that's very clear. Never a problem for us to understand. Then you see on the upper right-hand side the CO-17. Here you've got the group code and the CARC together. The CARC being a Claim Adjustment Reason Code. And when you have the CO-17, CO, remember, means contractual obligation, with 17 meaning that you're going to receive a development letter on this particular line. And we'll talk more about what that is. That has to do with a prepayment review. So that's alerting you that you're going to be receiving a prepayment review on that particular line item. Also, then we have the RARCs at the bottom. You'll see where they're listed, and giving you an outline of how you can find those. Now, all right, so what do these things mean? Is there a dictionary, and where do I find it? Within the tab 10, I did upload I think it's a 150-page book that CMS has written for us. It does not have every WARC or CARC or PLARC or group code in there, but it does give someone put a lot of attention and diligence into writing this book on RAs specifically, so that you would understand. Also, at the end of your section, I did put quite a bit of underneath resources where you can find information on the updates for these particular codes. And these codes are actually updated 3 times a year to a specific website, so that way you can review if you're so interested in that. And within your binder, you're going to find underneath each jurisdiction section, you'll find resources for you on really understanding the RAs as well. So they're going to go in just a little bit further with you. Here's some more. Here's some more RAs just to take another quick look. You'll see that on the top one far right side below, it says CO, contractual obligation, and 45, national competitive bid. This was interesting. They told me that they were not paying me certain types of monies because of a national competitive bid, which was incorrect, because obviously we're not underneath that. So that's where I was able to give Cigna a call and tell them, hey, what's going on here? And they were able, and there was actually some sort of problem with their system that they actually had to rerun everything and then pay everyone out again. So it's well worth looking at. The anti-denial guide, we'll just spend a very little time on this because not all jurisdictions have it, but I was able to find. I only saw where jurisdiction B and C have one. And basically what this does is this addresses claim denials in the most efficient manner. So it's the most common denials that you'll see. You see the answer remark codes on the far left, the remark codes in the middle that you receive on your RA, and then the explanation and things to do and next steps. I think this is great because it really captures the most common scenarios and helps you determine whether or not you need to reopen this particular claim line, or either submit some sort of redetermination first level appeal. And so you can see that very clearly here in this example, that due to MA 130 remark code, the claim was returned unprocessable, depending on because maybe perhaps some signatures were not captured on a HCFA 1500 form. So it's just basically telling you, submit. You don't need to, you just need to correct it, make sure the signatures are there, and resubmit as a new clean claim, as a new and clean claim. Of course, if you're doing that electronically, that would never arise, that particular issue. All right. So how do you challenge a denial? All right, so we know that we do get denials. All of us get them, and we all have to appeal them if we can. And, of course, we want to really take a close look at that. There's something called a reopening, and this is not a first level of appeal. This is just something that we would actually use if there is, if you actually, for example, transposed HCPCS numbers or ICD-9 numbers, or if there was a mass computation that was done incorrectly on your form of the items, then that's when you would actually make a phone call to your jurisdiction and say, hey, I just need to reopen this claim. If you could please just correct this without even having to resubmit it. And you can do that 12 months from the date if you do receive an RA from that. I'm so sorry. All right, so then let's take a look then at appeal levels, and there are actually 5 levels of appeal. You'll find that very clearly outlined for you within section, gosh, I can't remember which section we're on. Section 10. And within the Infonet, so you'll see that. So the first level of appeal is redetermination. Then we go to reconsideration. Then third level is administrative law judge. Fourth level is departmental appeals board review, or DAB. And the fifth level of appeal is a federal court review. The first 2 levels, there is no monetary threshold to be able to do those particular appeal levels. Each appeal level you'll see that is reached, there's a different group of people that do review your claim. And the higher you go, the more you'll have more attorneys, you'll have more physicians and nurses reading them and looking at the determination. I think it's really important here to stress, before you appeal something, you really want to make sure that you understand your policies and LCDs, because when you're resubmitting, that is what they're looking at. Have they followed the policy? Have they followed the LCD? Then you can resubmit for an appeal. I would definitely do that depending on the case. Okay. And then the last one, the federal court appeal, the monetary threshold for the claim has to be at least $1,300. And that does increase every year. There's a small percentage of increase every year, but this is the 2011 threshold that you see there. All right, so just some things to do and avoid. I did speak on some of this at the last slide. When engaging in a Medicare appeals process, of course, you want to be able to objectively determine whether there was an overpayment, whether the overpayment determination was improper. So you're looking at your claim and saying, yeah, this really was improper. It does not meet the policies, or it does meet the policy. I'm definitely appealing this. I do have my rights here in order. Also, you want to be able to assess the reimbursement dollars at risk by performing internal audits and take corrective action. So when you do assess these audits and you take a look at what you are looking to appeal, of course, you want to make sure that you're taking corrective action and making sure that these are, that they've implemented, because you don't want this to happen again, right? Also, you want to ascertain the cost that's going to be put in place. So your time is valuable. So how many levels of appeal do you want to go through? And if it's the principle of the matter, I do get that. But you also want to see if it's worth it to you and your facility. And again, and I can't stress enough that when you do appeal something, you want to make sure that you are researching the policy and making sure that it does not harm your position and assists it. If you have any questions, of course, on this, give me a call and we'll talk through on that point if it does. Excuse me. All right, so prepayment reviews. Let's get down into the nitty-gritty of why we're all here today. We are receiving, it's not when we receive a review, it's not if we receive a review, but it's when we receive a review. And I found it interesting to do, when I was doing the research for our class, was to really understand who was conducting the reviews and why. I always like to understand the why before digging into the more superficial. But first of all, a prepayment review is the review of documentation and records before the claim completes the processing. So as part of the audit process, these particular groups, and depending on the jurisdiction, the groups can change. Always for prepayment, though, within all jurisdictions, it is always the medical review department, and not always ZPIC. So I know with C and a couple of other jurisdictions, I believe B, that their ZPICs do participate as well, but in some cases, ZPIC does post audits as well. So as part of the audit process, these groups are verifying that not only you, the supplier, have submitted the correct information, documentation, and so on, but they are also auditing your contractor to make sure that they are following the appropriate fee schedule as well. All right, so the MRD, or Medical Review Department, which is an internal department to your contractor, they do make these reviews based on random-based initiatives. So, for example, if that particular day they're reviewing every 10th claim and you submit 60 claims that day, you'll receive 60 reviews. It just depends on how it falls. Six reviews, thank you. Their goal is to reduce payment errors by identifying and addressing billing errors concerning coverage and coding. They're the ones who also publish the LCDs and the policy articles that we look so closely at also. And just so you really are clear, those policies and LCDs are the same policies and LCDs that each of these auditors are reviewing as well. So they know them like the back of their hand, and so should you. ZPICs, what are ZPICs? ZPICs are Zone Program Integrity Contractors. And you'll see within tab 11, I've given you a nice bit of a book there on prepayment review and really broken out what ZPICs are. And these guys have been broken up into 7 different zones and responsible for certain states. And in creating these zones, CMS has created these zones, and they have particularly and purposefully targeted certain areas which fraud and abuse have been more prevalent. So when you take a look at that section, you'll see where, for example, in Section 7 is Florida, Puerto Rico, U.S. Virgin Islands. Well, the reason why Zone 7 is devoted almost solely to Florida is because it's considered a hot zone because of high incidence in Medicare fraud. Also, Zone 4, for example, Colorado, New Mexico, Oklahoma, and Texas. Texas is also considered a hot zone, as well as California. So these particular zones are really closely looked upon. But when I was digging down deep, and I thought it was interesting, the ZPIC audits in a lot of the zones are not really being covered yet because there's some arguing internally, and contracts have not been awarded by CMS to certain auditors and contracting groups. So Zone 2 and 5, 1, 2, 3, 5, and 6, and you can take a look at which zone you fall in, have not been awarded contracts yet for the ZPICs. So that means that if you're getting prepayment reviews, more than likely you're getting them from the medical review, and depending on your jurisdiction, it could be from CERT. All right, so why of all of this? In 2008, it was shown that 3.7% of the Medicare funds, equaling $10.2 billion, was actually given through overpayments. So in that case, the government did not believe that the trust fund was well protected. So this is why the ZPIC and the other auditors have now come more to light and to life as well. All right, so enough of that. Let's take a look at some of the most common medical review errors that are found. So Medical Review Department, that group, the internal group, this is what they're finding when they do these prepayment audits. They're finding that we, the suppliers, are not, and this is how we're not in compliance and we're failing our reviews. Our physician medical records that are submitted does not support continued medical need and use, meaning the SCP and the medical notes are not mirroring each other. The physician order errors, either not received were invalid, so the physician written orders were invalid, or either it was illegible, the physician's signature was illegible because it's not following the CMS signature requirements. That's very important. Also, written documentation of the dispensing order was not maintained. Somehow that documentation was lost, and it was not being able to be proved when an audit came about. A claim was submitted prior to receiving a detailed written order. As you remember in the last time we spoke, you can you have to have a written order in hand in this case prior to dispensing. I'm sorry, not prior to dispensing, but prior to submitting your claim. Also, missing written order elements. So on the written order, there are missing elements, meaning perhaps there is your client's name was not listed. That's definitely an element that should be there on a written order. I know that sounds simple, but in some cases it's missed. Also, proof of delivery documentation was not maintained. That's very important to show that you, the supplier, not only dispensed the footwear, but you looked at the footwear on your client's feet and saw them walking in it and so on. So we have to make sure we keep that documentation very clearly. And if you're using the information that we gave you last time, I think that will help you maintain compliance. All right, so the basic prepayment review process, how does that happen? Just quickly, let's just run through it. Of course, you submit a claim to the contractor. When, as I said, if they're picking up every 10th claim, then the claim system is stopped and it's put in waiting, and then a letter is sent to you just requesting additional information, additional documentation. And then that claim just stays in waiting until they receive documentation from you. You have about a 40-day time frame to respond. This does vary depending on who you receive the prepayment review from, so just take a real close look at that. I would say that's probably one of the most important points when receiving a review or an audit is looking at the time frame, because you never want to be considered a non-responder. And a non-responder is someone who does not meet the time frame, the 30-day time frame, 45-day time frame, 120-day time frame, depending on what that is, simply because that is considered a red flag and they're wondering why you haven't even bothered. In some cases, I know that you haven't yet received the medical notes, so maybe that's one reason why you haven't submitted. So what you'll want to do when you submit the documentation without the medical notes, you'll want to say, I have reached out to the physician, on this date, through email, through fax, and so on, and I still yet to hear from them. I'm still waiting for that. More than likely what will happen is that they will deny that claim, but you will have an opportunity to appeal it at that time. And therefore, when you do get the medical notes, that will be good, so you will be able to then get paid for that claim. All right, so next, paid or denied, and then whether or not the claim is denied, as I said, and if you need to go first level appeal, then you do. All right, so some of us haven't received a prepayment review, and perhaps we want to know exactly what that looks like. Within your packet, you will see in tab 11 there is a 5-page prepayment review letter, just so that you can take a look at what something like that does look at and what they're requesting. I think one of the most important things here to stress on when you're looking at that is that you want to make sure that when you submit the prepayment review, you fax it in, or you can mail it in, the prepayment review, you want to separate it out and use the verbiage that they use within their letter. So in the first section, you're going to be sectioning things out. You're going to have title pages. And I think this is the easiest way. If I was an auditor, I would want to be able to simply and quickly flip through the paperwork and not try to figure out what you've given me. So first section, development letter, you would title your piece of paper development letter. Behind it, you would put the development letter that they sent you, the request. Secondly, prescribing physician's order. Thirdly, completed and signed and dated statement of certifying physician. Then 4, relevant medical records. You put that behind that, and so on. Guys can read that through. But use the verbiage that they have given you to implement this. I think that's the easiest. I'm sorry, I have a cold, and I apologize for sniffling on the call. All right, so some important points to keep in mind when you do get a prepayment review. Again, note the due date given in the letter. You want to make sure that they receive a response prior to the stated time frame, so you're not receiving a denial, unnecessary denial. Also, note where to send your response. make sure you don't send it to the wrong office, because this will be a delay and possible denial, obviously. So within each letter, you're going to see how to respond, where to respond, and when to respond. When you do respond, as we had said in the last slide, make sure you put the request letter on top, and only respond one time. This is not going to hurry them up if you respond multiple times. This will only, honestly, slow down the process, because they're going to look at duplicates, and then they're going to start denying you for duplicates over and over again. If you do get multiple prepayment reviews at the same time, don't submit them all at the same time. Don't combine them all. You want to submit them all separately. So if you're mailing it in, send it in a different envelope. If you're faxing in, fax them separately. Okay? Let's see, where was I? So obviously you want to make sure you send all your documents for your response at one time, if that's possible. Of course, we gave an example when that is not necessarily possible, and that would not be your fault. If you did get a prepayment review and you are putting together the claim, but you decide, or for example, to go ahead and send a claim as well for that, don't do it. It'll be considered a dupe, and it really will slow down your process as well. Okay. Post-payment audits. All right. Let's see here. Sorry, flipping through my pages. All right, a post-payment audit, is completed after the claim has already been processed. So that is what it is. You've already received money for that claim, and now they have come back to you and have said, hey, we'd like to have that documentation to show that there was, in actuality, was not an overpayment in place. So I've put in very briefly what the statutory authority is for them to do that under the Social Security Act, in case you guys were ever interested in reading up on that. I won't go through that here. Also, just to take a look at who are the potential post-payment auditors. And they're all these 4 groups. And the new groups that we're talking about here on this particular side, I won't go back over medical review or ZPIC, but CERT group and the RAC. The RAC is the newest group of auditors that have just come about due to the Tax Relief and Healthcare Act of 2006. These guys are sort of low man on the totem pole that a lot of the other auditors dislike in a sense as well, because they work on commission only, if you will, meaning that they receive their payment from a percentage of the monies that they collect from you. When they have found an overpayment, and if their overpayment is correct, their monies, their salary comes from you. And it's funny how the other auditors think that's dirtier business than that. And I laugh at that. Anyway, all right. So what is a CERT? CERT is an external contractor too, and as I said, the only internal auditor are the medical review departments. Some of you guys are receiving CERTs. CERT reviews or CERT audits. And so what you want to do is take a look at the tab 12. Very clearly, I've outlined what a CERT does and who they are, if you're so interested in that. Whenever you receive a CERT audit, it's going to be very clear that of where you need to respond. Either you can make a phone call and speak to them about the audit, or you can go ahead and just send your information back into them, faxing it in or mailing it into them, depending on however you want to do it. So I'm not going to, because of time, I'm not going to spend too much time on the nitty-gritties of those guys, since you can read them on your own if you'd like. These are the different types of recovery audit contractors, or RAC, that do take care of each particular jurisdiction. And I do have within your resource section phone numbers as well as fax and email addresses if you ever need to get in touch with the RAC, if you ever do receive one of their audits. In short, payment audits this slide just speaks to the fact that they're just making sure and reviewing that you were not in actuality overpaid. Okay. And when you submit an overpayment audit, I would take the exact same thought that we had during the prepayment review section, where you are separating out with title pages and very clearly giving them information so that way they're not having a difficult time in understanding what you've submitted. Also, in being able to really follow that timeline and request, that is probably one of the most important components right there. So that way you stay within that 120-day timeline, because that's normally the time you have for that, of course, unless otherwise noted within the letter. All right, so what is an overpayment and refund? Sometimes it comes down to it where we have to return an overpayment to Medicare. And so in that case, I think it's important for you to understand, let's see, there within the tab 13, underneath each jurisdiction, I have given an outline of overpayment forms that you use. And I believe, and I can't remember now off the top of my head which jurisdiction, but there is only one jurisdiction that does not have an overpayment form letter. And in that case, you would actually write a letter and include these particular components. Have that put in the book that was created for that section, tab 13, if you can't, if you want to review at your leisure. But of course, using the form will make life a lot easier. Let's see, overpayment demand letter. Again, look at the time frame. That's very important. The first letter that you receive, you're not going to have to pay interest, because for as long as you keep the money that's considered overpaid to you, there is interest applied to that. So you want to make sure you don't have to pay that interest, so you want to respond timely. If for whatever reason you're out of town and your store is closed for a couple of weeks for summer vacation or whatever, if that ever happens, you want to make sure someone is collecting your mail and responding to these types of audits if necessary. So that way because the clock is always ticking. And the clock starts ticking actually from the date that is on the letter, not from the date that you've received the letter, but the date that's actually marked on the letter. It's very important to remember. All right, so of course, if for whatever horrible reason we don't respond to these overpayment letters and try to either appeal it or pay back the monies, then in the end, if a third demand letter is sent, intent to refer, then you're going to be referred to the Department of Treasury. And we don't want that, because then they will be actually offsetting your monies and collecting for Medicare. Of course, there's something called an ERP, or Extended Repayment Plan. So that way, if the overpayment is substantial and you're not able to afford paying that at that time, there are forms in place within each jurisdiction. You can find out within that packet online that I gave you. You can actually request for an extended payment plan, something similar to what the IRS is doing now. So if we have to pay back the IRS and we can't afford to pay them back the thousands of dollars that we have to, you can put together a payment plan for them as well. But of course, along with that, there's quite a bit of information they want to learn about you to make sure that this is the case. I did see an article put out by the Office of Inspector General, OIG, and one of their biggest concerns for 2011 is the fact that they have not been able to collect overpayments. So they are going to really be focusing on the fact that, do these physicians, suppliers, and so on, these people who have these overpayments out there, are we, Medicare, federal government, really putting everything we can in to make sure we're collecting that? And then I think the last important point to bring up just within this section is voluntary refunding. Sometimes you're going to find, perhaps if you're doing a self-audit, you're going to find that you need to voluntarily refund some money to Medicare. Perhaps that you have been billing the wrong HCPCS code for something, and it should have been something else. So you don't want to wait for Medicare to request the monies and to find the issue. You want to go ahead and resubmit that. To be able to do that, I've put a nice outline for you within your booklet for you to follow on that as well. All right, last very important point. What is the best way to prepare for an audit, or the best way to prepare for the review? Well, it all happens in the beginning, as we know. During workshop part 1, I spoke at length about something called an intake form. And if you've forgotten to take a look at that, please go back and do so. This is a form that has been specifically created just for you, Foot Solutions. You can choose to use it if you'd like or make up your own, but it does follow the policies and the LCDs across the board for all jurisdictions for you to check the box and make sure that you have everything in your hands that you need. And I tell you, on all the webinars and all the one-on-one calls and everything with the various jurisdictions that I have spoken with, they cannot stress enough for us to use an intake form. They believe this is really the way to succeed. All right, 9:34. We have 20 more minutes, so let's go ahead and start taking some messages, some answers, or whatever questions. Excuse me, I can't talk. And before I take us off of mute, I'm going to go ahead and just start looking through the different questions. Whatever I can't answer here, I'll definitely take back and send up to everyone at that time. Elaine, let me just, well, I'll just take us off of mute and answer Elaine's question and see what she has.
The conference has been muted. The conference has been unmuted.
Hey, Elaine, your hand's raised. Would you like to ask a question?
Actually, I'd like to offer a comment. I've been doing my Medicare billing myself pretty much since day one.
Right.
I've had a couple of occasions for voluntary refunds, particularly in a case where you get a non-compliant person that you just need them to go away, and you take the shoes back and you've already billed it and you need to refund Medicare. I've had some redeterminations. What I have found 100% with Medicare is that if you're confused and you don't know what to do, if you call them and let them know that you're just trying hard to do your billing correctly, they're very helpful. They're not out to get you. They're just they're trying to help you through it. So I would say don't hesitate if you're ever confused about that to call them and say, I've got this, I don't know what to do with it. So I just wanted to share that. They're not people to be afraid of.
Thank you, Elaine, for that. I couldn't agree more. I know that I've called them, a number of times, and they're always very helpful and generous with their information. I'm sorry.
Got yours right after ours.
All right.
31st of July, but just...
I'm going, if you guys don't mind, just make sure you put your phones on mute. I won't put us back on mute group. And go ahead and answer the chat questions. Let's see. The first question is, why would you bother with this since the customer won't want to pay and Medicare won't pay? Oh, okay. This is a question that came from right at the beginning with the advanced beneficiary notice. We were speaking to that. So in essence, the question is, why would you bother with the ABN if the customer won't pay and Medicare won't pay? Well, if the customer's there, you're educating your customers well, obviously, with various things that you need to do to be able to bill Medicare for their diabetic shoes. So what you'll want to do is, in some cases, the customers will pay. Of course, it depends on the finances of that particular customer, but it's all about educating them and letting them know and empowering them and saying, you know what, I don't have, for example, the best medical records from your physician. Perhaps you'll want to go and speak to them about it. I have not been able to get a response from them. And if they say no, thank you, then you go ahead and have them sign the ABN. And that way you know up front that you'll be paid for the dispensed footwear. And if they won't sign it, then you know not to give them the footwear, right?
You just been having them sign.
That makes sense?
Just a copy of which.
All right. Customers come in late December, so this would not give us enough time to get the medical records. Can the customer sign an ABN to get the shoe before 2011 ends? All right, so in this case, here's another ABN question, where if a customer comes in late December to get their footwear, this particular franchisee is concerned because it's not giving her enough time to gather the medical records. No. Therefore, can the customer sign an ABN to get the shoe before 2011? No. Well, hold on. One of the main points of being able to use an ABN is that you must know, if we go back and look at the notes, you must know that it is not going to be the item is not going to be medically necessary. And at that time, without seeing the medical notes, we don't know that. We don't know if it's not medically necessary or not. Therefore, you can't have them sign it because it would actually be probably considered more like a blanket or generic ABN, which would be considered a defective ABN. If you use an ABN without the KX modifier, can you appeal? No. No, you can't use an ABN without the KX modifier, meaning when you bill the diabetic footwear, because nowadays when you are billing diabetic footwear, to be paid, you have to bill along with a KX modifier. I've seen in a number of places, so I haven't tried this myself to bill without KX modifiers because of what I've seen written, but I've seen a number of places now that if you do not submit, when you bill for diabetic footwear and you do not submit a KX modifier on each of those billing lines, then it will be denied without opportunity to appeal. If any of you guys out there have a different experience than that, please let me know, because I'm going off, again, what I have read. So to answer to that, you have to bill a KX modifier along with the GA every time.
Stephanie?
Ma'am.
So going back to the customer that comes in late, and you don't have time to get their medical records, could you just tell them that you cannot dispense a shoe because you need the medical records and they should think about coming in to get their shoes in October and November?
Well,
so we can, or do you just go ahead and dispense the shoe and hope that you get the medical records to support the certifying statement?
Well, that's certainly a business decision. I hear exactly what you're saying. There is no place in the LCDs or the policies within all jurisdictions that state you must collect the medical records prior to billing or dispensing footwear. So you certainly can do that. So, you know, what maybe moving forward, you know, it depends on, I guess, you know, you're right that if you have guys coming in every December 26th or December 28th to get their footwear, then that for that particular year, then that's when they do it. I know of one franchisee out there that I've been speaking to quite a bit to her about this, and what she does is she services that particular Medicare diabetic person every time, you know, during that one visit. So they come. But so before they come in, she makes sure to get all of their information, even the medical records. That's been her business decision to collect that. She has all her paperwork in order, and then then they make the appointment for them to come in that one time where she evaluates and dispenses them, and they come in one appointment and they're gone after one appointment. Maybe that's the way to do it for you. I don't know. Okay. Did that help your question?
Well, I guess, again, you're just going to be giving them the shoe not knowing if you're going to get paid for that bin.
Right. It all depends on the medical notes in the end. As long as you're doing all the notes that you should be, you're completing all the notes that you should be completing, yes.
Thank you.
Okay. All right. Next question. Next question, where are the documents for this webinar and last? Ran late with traffic. Okay, it's on the FS Infonet. If you guys go there, it's underneath Medicare documentation, underneath the Foot Solutions library. And then when you click on Medicare documentation folder, then it'll automatically open up and you'll see the two, Part 1 and Part 2 Medicare relaunch. So all the documents are there. And if you have a problem with that, please don't hesitate to call me later and I'll walk you through where to find it. Next question, when seeking medical records, can a form be devised so we don't have to get 25 pages of medical notes? You know, unfortunately, no. Again, and I say this because I have, again, in one-on-ones and webinars, and I have seen it within the policies as well, that they want to see a comprehensive diabetic plan, a review that the certifying physician has done on their patient. So meaning this is somewhat of a SOAP note. We went over what a SOAP note was last time, subjective, objective, assessment, and plan. They want to see that not only that, the feet have, of course, that the feet have been reviewed, that they have diabetes, they have one of the secondary conditions that are required for the diabetic shoes, and that the assessment from the physician is that they need diabetic shoes. That needs to be in there. This patient needs diabetic shoes. And no, you really can't get around that. I know when I went to Charlotte for a Medicare conference, someone else asked the same question, and he said that. He said, you know what, you need to get, if all the notes are from that particular visit, then you need all the notes. That was what he said. When we submit claims, are we supposed to submit the actual costs of the Medicare limits? We were told they use these figures to base next.
You have a lot of scrap paper.
Okay, let me read this again. When we submit claims, are we supposed to submit the actual costs of the Medicare limits, so the allowable? We were told they use these figures to base next year's reimbursement rates. Would you mind rephrasing that? Who asked that question? I'm sorry, I just want to make sure I answer it correctly.
Hi, it's John.
Hey.
Hello? Yeah. The question is, when we submit claims, are we supposed to submit the actual cost or the Medicare? In other words, if we have a shoe that goes for $165 and we're downgrading that to $133.38 because that's what Medicare pays, we've been on the form. We've been putting the code in 165 on there, knowing that it would be denied down to the limit. That's the way we've been submitting them. Are we supposed to do it that way or not?
Okay, good question. I'll have to check in and see if which way, if that's actually how they determine the allowables from year to year, because I'm not sure if that is it. But you can submit the billing in both ways. You can do either one. You can submit it with the pricing that you do use across the board, or two, you can submit it with the allowable only. That is up to you. It is a billing practice entirely. And I've actually asked that specific question to Jurisdiction C actually on that. So they don't care either way, as long as if you're billing over the allowable, obviously that you make sure that you cut the cost and you're only billing the Medicare beneficiary for the amount and so on, and you accept payment rendered. Does that make sense, Nick?
Yes, it does. I mean, they don't cover the deluxe features, correct?
Right. They don't cover the deluxe features, but again, if you do use that ABN for the deluxe feature component, then it would be the Medicare would say that the beneficiary was required to pay for that portion of it, and then
but it's not covered by Medicare. Right.
As long as you have an ABN on file, and you
okay.
bill accordingly. But an A5508 deluxe feature is non-covered. Otherwise.
Thank you. Okay.
Yep. Dr. Bill's just reminding us about the ABN, and we want to make sure that they have it signed. We talked about that at the beginning. No. All right. So next question. Can you make corrections after the fact?
And I have a copy of...
Can you make corrections after the fact to win an appeal? Can you make corrections
one that
after
you've already done, so I
an
can...
appeal? Hey, Vic, this is you again. Would you mind giving me an example? Can you make corrections after the fact to win an appeal?
Yeah, I mean, if they've picked up on something, I mean, it goes. These folks don't know about Henry Blair, but I mean, did I waste my time on that? I had issues with the prescription being incorrectly filled out by the doctor. I went back a year later and had him write a letter, and I included that in my appeal. It looks like I'm not going to win that. Is there a time when you can make a correction?
Yes. Let's see.
Yeah, for sure. I think the main concern on that particular client's an issue was the fact that it took you 1 year to notice that the written order was not correct, and the correction wasn't made earlier. I think that was one of the most concerning points of it, and that's it's an odd. It's odd, but they want to make sure the documentations are all up to par. So, all right. You can make corrections definitely after the fact to win an appeal, depending on the corrections you make. But the earlier you make the corrections, the better. So you want to make sure you have the intake form in hand. You want to make sure you're looking at the documentation as you receive it, the SCPs, the written orders, et cetera, et cetera. So that way you make them quickly. With the paperwork you guys have now, I think you will definitely be able to stay on top of it. Do the records have to state the patient needs diabetic shoes if the conditions are spelled out? Yes. The records do need to state that the patient needs diabetic shoes if the conditions are spelled out. And I think what you're saying here is within the plan portion of the medical notes and the assessment portion, does the physician need to say they need diabetic shoes? And yes, they do, because they need to, and perhaps they've shared it verbally, but maybe they forgot to write it down. So it needs to be written. Medicare firmly goes by this: if it's not written, it never happened. Period. So whether the supplier, the provider, the physician, whoever, if you didn't write it, it didn't happen. All right, next. Can we always fax in these records for review? Meaning the medical records? Sure. And I think when you say we, that means you, and then to us, yeah, sure. I'm happy to always look at them. Dr. Bill is always happy to look at the medical records. Absolutely, Vic. All right. If you pay an overpayment, how do you know how much interest, et cetera, to close out the claim? They will let you know the interest due, for sure. If you are unclear, make that phone call. All right, next question and last question. Send a letter. Thank you, Elaine. I think this is great information. Send a letter to all your clients in October, reminding them to come in early. If they show up on December 15th, tell them you'll be happy to dispense the following year. Wow, I think that's great advice, Elaine. Thank you. So for those of you at the beginning of the Q&A, when you're concerned of getting someone in on December 29th and not having time to get all the notes and everything in place, you need, the onus has been on you put on you by Medicare. You need to put the onus on your customer as well. So it's just a business process you have to put in place. Okay, so that's the end of the chat questions. Do we have any live questions?
Stephanie?
Yes.
Yeah. My phone cut out. I had to jump back. When you pay an overpayment, how do you know about the interest?
Oh, okay.
Did you answer that?
Yeah, sure. No, I just said that you definitely will know of the interest. You should have it in the letter because I think you did submit a second level appeal, correct, Quick? I believe you did. So when you receive, and if you receive a denial, we don't know. It might be approved. If you receive a denial, they will tell you in that letter what the overpayment is plus interest if they do actually have you pay that interest. If not, at that time, I would definitely make the phone call. They'll let you know. So.
For now.
Okay.
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 Another question? We've got 5 minutes, y'all. We still have time.
Where's your mute?
Okay, next question is, where are the webinar links
Oh,
located to review later? Oh, they're all located on the FSNet under schedules and webinars. So when you see the you pull that up, you see the calendar, make sure you scroll down, and we will be there. Okay? Any other questions, guys?
Stephanie, will any of the other Medicare plans audit, or is it just Medicare?
You mean any of the other jurisdictions, or do you mean Medicare?
I mean, not everybody has Medicare now. Some of them have Medicare Advantage, Humana, Care Improvement Plus. Some of these others that are.
Right.
Do you think they're going to be auditing just like Medicare does?
I think eventually. I know that a lot of the commercial carriers, meaning the Humanas and the Aetnas and the Blues, who have the Advantage plans now, a lot of them are really reworking their policies to mimic Medicare and the documentation requirements. So I think eventually, yeah, they will. If they're not already, they will.
Okay, thank you.
Sure. Hey, Janice, give me a call after. We'll talk. Any other questions?
Hello, Stephanie.
Hey.
Hey, how you doing? This is Earl and Carrie at Yorktown Chesapeake Foot Solutions. When you were given the webinar links for later review, I was disconnected. Can you give me that again?
Oh, sure, no problem. Well, you'll just find on the FS Infonet underneath Schedules and Webinar, I think the tab is at the top. When you click that, you'll see the calendar, and you'll make sure you just scroll down.
I see it. I
all
see it
the
right
links,
here.
all the recording links are there from all the things that have happened.
All right, perfect.
In there.
Perfect. Thank you.
Thank you, sir. Any other questions?
We'll get the quiz just sent to us again, or?
Yes, you will. Those of you, and actually those of you who watch the screen, you will receive the quiz automatically. Those of you who just called in, you need to send Betty or me an email, and then we'll know that you're on there because you actually don't get listed, so we don't know that you attended. Okay?
Then you just click it on and it'll come on.
Right here.
All right, guys. Thank you.
Great job. Feel better, Stephanie.
Sir?
Feel better.
Thanks. I appreciate it.
Thanks, Steph.
Thanks, guys.
Thank you. Please stand by.